Good morning. For today's rounds, I'd like to present the case of Marcus. He's a healthy 38-year-old man who came into the emergency department late last night, and his chief complaint is severe acute diarrhea. Now, Marcus has no chronic medical conditions, he takes absolutely no daily medications, and 0 recent hospitalizations, so a healthy guy. The history of his present illness really starts 4 days ago. He was at a backyard cookout, and he had several pieces of undercooked chicken. And here's the kicker. We found out that a housemate who ate the exact same chicken is also currently sick. So right out of the gate, we've got a really strong epidemiological link. As I walk through his admission today, my goal is to really dissect the underlying pathophysiology behind every single clinical decision we make for him. We need to deliberately contrast an inflammatory colonic process against a non-inflammatory secretory diarrhea. And, crucially, I want to highlight exactly where standard empiric treatments can actually cause devastating harm if we misclassify him. Okay, let's look at the exact trajectory of his illness, because, honestly, it is highly localizing. On day 1, his symptoms started with his crampy, generalized lower abdominal pain and a few loose, watery stools. By day 2, the systemic inflammatory response really kicked in. He developed fevers, shaking chills, and just pervasive nausea. But notice this, he experienced almost 0 vomiting. Then, on day 3, he reported a major shift. He was having 8 to 10 stools, but they were very, very small in volume. And yesterday, day 4, he presented to us with severe urgency, marked tenesmus, and visible, gross blood in his stool. You actually asked a fantastic question during bedside rounds earlier. Why does a falling stool volume with a rising frequency inherently localize the pathology to the colon rather than the small bowel? Well, the small bowel processes massive fluid volumes. When it's inflamed or actively secreting, you get voluminous, watery output. But as an infectious process travels down into the much lower capacity colon and rectum, that local tissue becomes highly inflamed, edematous, and irritated. The inflamed rectum literally loses its normal compliance and capacitance. It simply cannot stretch to accommodate stool anymore. This hypersensitivity of the stretch receptors triggers a constant, agonizing urge to defecate, which is the very definition of tenesmus, even when there's barely a tablespoon of volume left in there to expel. That late arrival of visible blood alongside the tenesmus, that is a massive clinical clue that the mucosal barrier of the colon has been breached. Looking at his objective data on admission, his vitals definitely confirm he is systemically toxic and severely volume depleted. His temp is bumping at 38.7 degrees Celsius, heart rate is tachycardic at 112, and blood pressure is a pretty soft 104/62. And yes, he had frankly positive orthostatic changes when we had him stand up. On physical exam, he's got dry axilla, completely tacky mucous membranes, and a delayed capillary refill of about 3 seconds. His abdomen is soft, non-distended, but he has diffuse tenderness that is by far the worst in the left lower quadrant. That gives us our second anatomical hint, pointing straight to the descending colon and sigmoid. We did perform a rectal exam, which revealed brown liquid stool with clear streaks of frank blood. Now, to answer your other questions before we get into the pathophysiology deep dive, I really want to defend my diagnostic choices here. First, his nearly complete absence of vomiting strongly argues against a preformed-toxin process. Those typically hit the upper GI tract rapidly and forcefully. Second, I purposefully deferred sending a C. diff test. Why? He's had no hospitalizations, no recent healthcare exposures, and no antibiotics in the last 3 months. The pretest probability is just vanishingly low. And furthermore, I am not sending stool, ova, and parasites. His acute 4-day timeline and total lack of exotic exposures simply don't meet any of the strict clinical triggers for parasitic testing. We are squarely dealing with an acute, likely bacterial, community-acquired pathogen.
Act 2, the master split and pathophysiology. To truly solve this case and manage Marcus safely, let's establish the underlying framework that dictates our treatment.
It all starts with normal fluid handling in the GI tract. A staggering 9 liters of fluid enters the small intestine every single day. You only actually drink about 2 liters of that. The other 7 liters are saliva, gastric juice, bile, and pancreatic fluid. Normally, the highly efficient small bowel reabsorbs 8 liters of it right off the bat. The colon then absorbs roughly 0.9 liters, leaving a mere 100 to 200 milliliters to exit in the daily stool. But what's critical to remember is that the colon possesses a massive colonic reserve. In a healthy state, it can ramp up its absorption to handle 4 or 5 extra liters of fluid a day if it really has to. It's a powerful buffer. So clinically significant diarrhea only really appears when that colonic reserve is completely overwhelmed, either because the small bowel is just dumping massive amounts of fluid that exceed the colon's max capacity, or because the colon itself is too inflamed and damaged to absorb its normal share. And this brings us to what we call the master split. Nearly every GI bug we deal with on the wards lives squarely on one side of this line. It dictates whether we're looking at a non-inflammatory small bowel issue or a destructive inflammatory colonic invasion. In a classic non-inflammatory process, think Vibrio cholerae or enterotoxigenic E. coli, an enterotoxin binds directly to the small bowel enterocyte. Adenylate cyclase switches on, intracellular cyclic AMP rises, and the luminal chloride channel is forced wide open. Chloride pours into the lumen, and sodium and water just passively follow that osmotic gradient. But importantly, the intestinal villi stay completely intact. There's no tissue destruction. So you get voluminous, watery stool with zero white blood cells or blood. Marcus, however, does not fit this profile at all. He sits entirely on the inflammatory side, which is characterized by small volume stool, left lower quadrant cramps, fever, and as we saw, visible blood. Zooming in on the cellular level during an inflammatory invasion, we can see exactly why his symptoms manifest this way. The organism doesn't just secrete a toxin, it actively invades the colonic mucosa. The protective epithelial barrier is physically breached. This triggers a massive localized cytokine release, and neutrophils immediately flood into the surrounding tissue to fight the invasion. As a result of this microscopic war, the mucosal surface physically ulcerates, dies, and breaks down, allowing frank blood and pus to leak directly into the stool. Because the colon's absorptive surface is being destroyed, stool volume inherently falls, but the frequency skyrockets. And as we discussed, that inflamed rectum drives the unbearable tenesmus. This invasive mechanism perfectly explains Marcus's exact presentation, from the LOQ pain right down to the bloody streaks. Based on this, I'm fully committing my assessment to an invasive inflammatory colitis. The physical exam completely justifies it. Just to firmly close the door on our bedside discussion about food poisoning, we can entirely rule out classic food poisoning from preformed toxins. Organisms like Staph aureus in meats and dairy, Bacillus cereus in fried rice, or Clostridium perfringens in rewarmed meats, they produce their enterotoxins directly in the food before you even take a bite. Because there's no bacterial replication or gut colonization required inside the host, the onset is incredibly fast. Staph aureus hits within 1 to 6 hours, C. perfringens within 8 to 16. Vomiting heavily dominates the clinical picture, and because the toxin is rapidly flushed out, the whole shebang is completely over inside 24 hours. Marcus has been progressively sick for 4 solid days with a fever. Preformed toxin is definitively off the table. Armed with our physiological framework, let's transition to evaluating his laboratory results to lock in our assessment and our ward management plan. His labs returned with a white blood cell count of 14,200 with a prominent left shift. That confirms a systemic bacterial response. His sodium is 132, potassium is low at 3.1 from GI losses, and his bicarbonate is low at 18. That's a non-anion gap metabolic acidosis, directly resulting from severe stool bicarbonate loss. We also sent a fecal calprotectin, which is a highly specific marker for neutrophil degranulation in the gut lumen, and it returned markedly elevated. That definitively proves active mucosal invasion and wipes out any lingering thoughts of a purely secretory process. But the lad we really need to focus on today is his creatinine. It's bumped significantly to 1.6 from a known healthy baseline of 0.9. We face a very serious competing explanation right here. Is this simple prerenal azotemia caused by 4 days of profound hypovolemia and poor oral intake? Or, conversely, are we looking at the early acute kidney injury phase of hemolytic uremic syndrome triggered by a Shiga toxin? If Shiga toxin-producing E. coli invaded his colon, the absorbed toxin could currently be binding to the glomerular endothelium in his kidneys, kicking off a microangiopathic disaster. Now, given his severe orthostatics and tachymucous membranes, I am committing to prerenal hypovolemic AKI for this morning. But HUS must remain an active competing diagnosis on our problem list, and I'll outline exactly how we monitor for that trap in just a moment. Matching his specific undercooked poultry exposure and his highly inflammatory symptom profile to our diagnostic list, Campylobacter jejuni is our leading infectious suspect. It's notorious for colonizing undercooked poultry. Interestingly, it often presents with this exact prodrome of severe, crampy abdominal pain that can be so localized and intense that it mimics appendicitis. We call it pseudoappendicitis. This perfectly justifies the intense left lower quadrant pain we noted on his exam. Salmonella is also possible, again linked to poultry, which is exactly why we sent peripheral blood cultures on admission. Salmonella causes invasive bacteremia in 5 to 10% of cases. Shigella is less likely since there's no known person-to-person outbreak, though it would explain the gross blood and pus. Now, the crucial decision point, applying the warning signs to determine who actually gets empiric antibiotics versus who receives purely supportive care. Most acute infectious diarrhea, even when it's absolutely miserable for the patient, is completely self-limited. We do not treat everyone. However, we look for red flags that warrant escalation to targeted antimicrobial therapy. The list includes fever, severe abdominal pain, blood or pus in the stool, more than 6 stools per day, severe volume dehydration, states of immunosuppression, age over 70, or hospital-acquired onset. Marcus hits local major criteria here. He has a documented fever, severe localized pain, bloody stools, well over 6 stools a day, and severe dehydration. He clearly meets the objective criteria for escalation.
Act 4. Let's finalize his ward management, highlight the major treatment pitfalls, and discuss his eventual disposition.
The absolute foundation of his treatment plan hinges on fixing his severe volume depletion. Rehydration is what literally saves lives in these cases worldwide. For moderate depletion, standard guidelines aim for 50 to 200 milliliters per kilogram per day of oral rehydration solution. But why do we use specific oral rehydration solutions instead of just telling the patient to drink plain water or soda? Well, plain water fails because it lacks the precise sodium-glucose coupling required for optimal absorption. Even when aggressive bacterial enterotoxins completely block the standard sodium absorption pathways in the gut, the SGLT1 transporter, that glucose-coupled sodium transporter, is left entirely unaffected. It creates a brilliant cellular backdoor. As long as you provide sodium right alongside glucose in the correct molar ratio, the gut will forcefully continue to pull sodium, glucose, and water across the intestinal wall, totally bypassing the toxin's blockade. However, because Marcus is severely volume depleted with an actively rising creatinine of 1.6 and ongoing nausea, oral intake just can't keep up right now. Our plan is aggressive IV fluids with potassium repletion to correct his hypokalemia. For his targeted antibiotic therapy, we're giving a single 1-gram oral dose of azithromycin. Historically, we would have used a 3 to 5 day course of a fluoroquinolone like ciprofloxacin, but azithromycin is now preferred due to heavily rising widespread fluoroquinolone resistance, especially in campylobacter isolates. Crucially, we must firmly hold loperamide. In a patient with active mucosal inflammation, fever, and bloody stools, paralyzing the gut motility with an agent like loperamide traps the invasive, proliferating organism inside the colon. That severely increases the risk of prolonged systemic illness and potentially fatal toxic megacolon. Bismuth subsalicylate could be considered later for symptom control, but absolutely no loperamide. As a quick word aside, if Marcus had presented with standard, voluminous, watery traveler's diarrhea without fever or blood, a non-absorbable, lumen-acting drug like rifaximin would be perfect. If we suspected a protozoal cause like Giardia, we'd reach for metronidazole or nitazoxanide. But for an acute inflammatory dysentery like this, azithromycin is the drug of choice. But wait, because hemolytic uremic syndrome remains a competing explanation for his elevated creatinine, we have to pause. Before you automatically hand out antibiotics to every severe, bloody diarrhea case on the ward, you must consider the one massive clinical exception that could literally destroy your patient's kidneys.
This is the great management trap. If a patient presents with gross blood in the stool and their history reveals exposures like undercooked ground beef, unpasteurized milk, or unwashed raw produce, you must suspect Shiga toxin-producing E. coli, specifically the O157H7 strain. If STC is suspected, you must absolutely hold all antibiotics, aggressively hydrate the patient, culture, and wait.
To understand why this is a trap, look at the mechanism of the Shiga toxin. When STEC adheres to the colonic epithelium, it operates somewhat stably. But if you blast that bacteria with empiric antibiotics, you lyse the bacterial cell walls en masse. This destruction causes the dying bacteria to release a massive, overwhelming wave of Shiga toxin all at once. This immense toxic load is rapidly absorbed into the bloodstream, where it specifically targets and binds to the glomerular endothelium in the kidneys. This binding causes severe, immediate endothelial injury, leading directly to the shearing of red blood cells, which is microangiopathic hemolytic anemia, plunging thrombocytopenia as platelets get consumed in microscopic clots, and profound acute kidney injury. That is the classic devastating triad of hemolytic uremic syndrome. That is exactly why, if STEC is ever on the table, you hold the antibiotics and you watch their daily platelets and creatinine like a hawk for a full week. If Marcus's platelets start dropping tomorrow, that instantly changes my mind from prerenal AKI to HUS, and we'll have to image him for toxic megacolon as well. Looking toward his disposition over the next 2 to 3 days, I want to leave the team with a few core teaching pearls. First, regarding testing. Never blindly order stool ova and parasites on every diarrhea admission. It's an extremely low-yield, expensive test unless the patient definitively meets one of these 6 specific clinical triggers: symptoms lasting longer than 10 days, recent travel to an endemic area, exposure to unpurified water, a known community outbreak, direct daycare exposure, or if the patient is HIV positive or a man who has sex with men. If they don't meet these, the test won't change your management. Second, Beware the clinical pitfall of our highly sensitive PCR panels. The multiplex DI panel tests for 22 organisms simultaneously. It has an incredibly high positive rate, but it cannot differentiate between a true, active, tissue-invading infection and harmless asymptomatic colonization. For instance, if a patient is merely colonized with C. diff but presenting with viral gastroenteritis, treating the PCR result with oral vancomycin is actively harmful. You have to use this panel with care, mostly reserving it for severely immunocompromised hosts, and always remember the golden rule: treat the patient in front of you, not the printout.
Finally, for Marcus's trajectory. We'll repeat his basic metabolic panel in the morning to check his renal function and potassium and await culture turnarounds. He needs to show objectively improving vitals and falling stool output before we even consider discharge. But if his stool cultures return completely negative and he simply isn't improving with our azithromycin and fluids, we can't blindly anchor on an infectious etiology. We must reopen the differential. We'd have to seriously consider things like a first severe flare of inflammatory bowel disease, which would require an inpatient colonoscopy. We'd also have to evaluate for systemic drivers like hyperthyroidism, surgical masqueraders like appendicitis or diverticulitis, or, especially in older populations, severe medication side effects like checkpoint inhibitor colitis.
By keeping this core non-inflammatory versus inflammatory framework locked in your mind, the next time a patient presents with acute diarrhea, you can simply ask yourself about the volume, the frequency, the fever, and the blood. Knowing which side of the master split they land on allows you to safely crack the case, avoid the dangerous traps, and deliver the precise, targeted therapy required. I'll leave you with this final provocative thought. If a simple backyard cookout can trigger a cascade that threatens the kidneys in a matter of days, how many other routine cases of gastroenteritis that we casually dismiss are hiding a microangiopathic disaster right in plain sight? That concludes my presentation for Marcus.